Okay, should I start? Are you there, Idris? Okay, great, thank you. So let me close the chat. I cannot see anything. So hello, everyone. My name is Rakan Alhabib. I'm a second-year medical student, and we'll be going over the cardiac output and venous return lecture today, inshallah. And hopefully it's going to be an easy lecture. We just have to outline a couple of points, okay? So I'm guessing you already know the outcomes or the objectives of this lecture. Once you know the objectives and you know exactly what the doctor wants, it becomes a pretty easy lecture, to be honest. And also at the end, we'll be solving like 3 questions together, and so we can see how you can solve these questions and how you can approach them in the exam. Now, in the beginning, we're going to talk about the cardiodynamics. So I'm guessing you went over this with Dr. Abdul Jabbar. You explained what cardiac output is, okay, and the heart rate and stroke volume. So stroke volume is the amount of blood that is pumped by the heart per minute, per 1 beat, and the heart rate is the amount of beats per minute, okay? And is the amount of beats per minute. So when you multiply the heart rate by the stroke volume, you'll get the cardiac output, okay? Which is essentially 5 liters to 5.5 liters in a normal body, okay? And I'm guessing you also went through the end diastolic volume, which is basically the amount of volume in the heart before the heart pumps. So when the heart is stopped filling, basically, okay? And then the end systolic volume, which is the amount of blood in the heart after we pumped, after the contraction of the heart, basically, okay? And we talked about the stroke volume. And then ejection fraction is basically the percentage of the amount of blood that got ejected, because this end systolic volume remains in the heart after the heart already pumped, okay? And basically, if you multiply 120 times 0.6, because it's 60%, so 0.6, you'll get the stroke volume, which is 70 ml, which is the amount of blood pumped by the heart, basically, okay? And here he explains that there's more than one factors that influence the venous pressure. One of them is blood volume. If I have 5 liters normally, and I add 1 liter, therefore there's more blood, there's more volume, okay, occupying the vessels. And as there's more volume occupying the vessels, so the pressure will be higher, okay? The second thing is the skeletal muscle pump. So when you walk, your muscles of the lower limb will contract, for example. Okay, like for example, the gastrocnemius is a very good example of the lower leg. Okay, and when they contract, they basically compress these veins. So there's nowhere else for the blood to go but up. Okay, and eventually they will go to the heart. Okay. And then you've got inspiration movements. You didn't take pulmonary yet, but when you inspire, the pressure in the atrium becomes less, okay? And that's just related to the what you'll take later on, which is the intramural pressure, which is the pressure across a wall, basically. So you've got the wall of the atrium, and you've got the pressure outside, which is the thoracic cavity, and you've got the pressure inside the atrium, and that's basically it. And then you've got the activity of sympathetic nerves to the heart, which will increase contractility. They will increase the heart rate, okay? Which will eventually cause a higher venous pressure. Highest venous pressure will cause more blood going to the right atrium, right? And so more venous return. And so when you have a high venous return, you're going to have a higher atrial pressure due to the more blood reaching the atrium. And you'll have a higher end diastolic ventricular volume, and so the stroke volume will be higher, okay? So in here, he basically went through what we just talked about right now. So he said that the cardiac output is the amount of blood that is pumped out of the heart per minute, and it is one of the most important factors of the cardiac function, which is basically because it pumps blood to the whole body. Okay, and so if it doesn't do that, you cannot supply the organs with the blood. The venous return, basically the venous return is the amount of blood that is going into the heart from the veins, okay, from the inferior vena cava and from the superior vena cava, okay. And here he just says that, so in order for me to pump, for example, if I pump 1 liter of blood, okay, out of the heart, which is the cardiac output, I need to receive 1 liter of blood from the venous return, because you can't have less venous return and more cardiac output. Doesn't make sense, okay? Because basically the amount of blood that is getting in the heart determines how much cardiac output is getting pumped from the heart, basically. And then in this graph, he describes the cardiac index over the different ages. The cardiac index basically is basically the cardiac output putting into consideration or over the body surface, okay, body surface area, which is basically different between every person and another. So we might have long people, okay, but they're skinny, and we might have short people who are chubby, for example, okay, or short people who are also skinny. So it all determines the cardiac index. Basically depends on the body of the person. So in here he just says that the cardiac index is best at this level, okay, which is at 18 to 20 years old. And then after that, it's going to decrease due to the fact that these vessels are going to get rigid. That's one. Two is that the activity of the muscles will decrease, and the muscle mass, as you get older, the muscle mass will decrease and the fat will increase. That's it, basically, okay. And this mainly we're going to talk about in the next slide, but basically what he's saying that the amount of cardiac output is affected, okay, by a lot of things. One is the body metabolism. If my metabolism is high, for example, in hyperthyroidism, I have a lot of my cells are burning a lot of glucose. They need a lot of oxygen. So my blood supply or my oxygen demand and blood demand to these organs are going to increase. And so the blood perfusion to these organs are going to increase. Okay. Now, whether the person is exercising or not, when you're running, you activate the sympathetic nervous system, okay? And as you activate the sympathetic nervous system, you activate, the heart beats more, and there's more perfusion of the skeletal muscle so that you could run, okay? The person's age, as I just explained, and the size of the body, just as I just explained in the cardiac index. Now, the cardiac output is controlled by the venous return. We're going to get into this later on, but for now, we just went through this, okay? Next slide. Okay, so here, he just says that he just gives you an equation, which is the cardiac output equals to the mean arterial pressure over the total peripheral resistance, which is also the systemic vascular resistance. It's the same thing, okay? And you could also put it in another way.
I thought I don't have the thing. You can find the
Hello?
Excuse me, that was by accident.
No problem. Okay. Sorry. So basically, you could put mean arterial pressure equals to the cardiac output times the systemic vascular resistance, okay? And here he just says that cardiac output would be directly proportional to the mean arterial pressure, meaning if my cardiac output increases, my mean arterial pressure increases, which means if I pump more blood out of the heart, I'll get a higher pressure, okay? And then he just says that the cardiac output is inversely proportional to the systemic vascular resistance. So if you have more resistance of the vessels, you'll have less cardiac output. You'll have less accommodation of blood, basically, okay? And then here he comes into what we just explained in the previous slide, which is first things that would affect the cardiac output. One, things that would increase Beriberi is basically a vitamin B1 deficiency, okay, which is found in alcoholic patients. He didn't, I don't think he got into the specifics of this, and don't worry about this. Then he gets into AV shunts. So AV shunts, I don't know if you've taken this, but AV shunts is when you have basically a vessel that is connecting the artery directly to the vein, okay, without going through the capillaries. So this, for example, this occurs when we're in cold weather, for example, when your body wants to conserve heat, the AV shunt is opened and you close the capillaries that are going to the tips of your fingers so that you wouldn't lose them or something, or when you're trying to conserve heat, okay? And this would increase the blood pressure, so because you do not have that capillary phase which decreases the blood pressure, okay? And then you've got hyperthyroidism, just like what I explained right now, which is increased metabolism or increased need of oxygen demand from certain organs, and then you'll have increased perfusion to these organs. And you'll also have the removal of both arms and legs will cause less cardiac output, basically due to the fact that you have less vessels. So if you have less vessels, you're going to have less cardiac output, basically. Okay. Hypothyroidism is the opposite of hyperthyroidism. So you have less metabolism by these organs. Okay. So in here, he basically gets into the specifics of the equation. Okay. So what affects the venous pressure? You're going to have sympathetic nerves, sympathetic activity to these nerves. And so if I cause venoconstriction, I will increase the venous pressure, and therefore venous return would increase and atrial pressure would increase, and then I'll have higher cardiac output. Blood volume, if I increased it, I increase venous pressure, I increase venous return, again, cardiac output would increase. Skeletal muscle pump, as I just said, the inspiration movements. Plasma epinephrine is basically the same thing with sympathetic. You're releasing epinephrine, you've got higher contractility of the muscle, you've got veins constricting, and therefore you've got more blood, more cardiac output, and so on. On this side, he's just saying the things that affect the total peripheral resistance, basically vasoconstrictors and vasodilators. So a vasodilator would basically decrease the total peripheral resistance. Therefore, we can accommodate more cardiac output, okay? And a vasoconstrictor would basically constrict the vessel. Therefore, you can accommodate less cardiac output, okay? But higher systemic vascular resistance. That's it, basically. And here, so the body in a normal human being, in a 70 kilogram, as I said, adult, is about 5 to 5.5, 5.6 liters. 80 of that blood is found in the systemic circulation, okay? And 20% is found in the pulmonary or cardiac, okay? So 80% is found in all organs of the body except the pulmonary and heart. And so 20% is found in the heart and lungs. Now, out of that blood, all of it, 60% is found in the veins, which tells you that the veins are way more compliant than the arteries. So they act like a pool or a reservoir pool for blood, basically. Okay, and so systemic veins are 24 times more compliant than systemic arteries, and we're going to get into that slide later on. I think that was the most confusing slide of the PowerPoint. Do you have to memorize all the substances? What do you mean by substances? So, okay, so you don't have to memorize them. You just have to understand them, because basically we're gonna go over the questions I brought up in we prepared in the ending of the PowerPoint. But you don't have to memorize them all. Just understand the fact that, for example, the release of norepinephrine will cause higher cardiac muscle contraction. Okay, and the effect of sympathetics, I think you've already taken this. The effect of sympathetics is basically fight or flight. So you're gonna want more heart rate, more cardiac output, and so on. And I believe you've taken angiotensin with Dr. Peter. Angiotensin, vasopressin. Vasopressin is basically ADH, epinephrine, atrial natriuretic peptide. I think you just went through it. He didn't really explain it. I don't remember if he explained it well last year. Did you took? Oh, okay. So okay, great. So you just need to know the main ones. Okay. So just understand the concept more rather than just memorizing, because if you memorize it, you may get confused, to be honest. Does that answer your question? Okay, anytime. So we were here. So he basically says here that the systemic veins are more compliant, and I said we're gonna go over this later on. And then he just gives you a hypothetical problem where if we infuse 500 milliliters of blood into the circulation, 80% of it will go to systemic circulation, and then the 20% would go to the heart and pulmonary system. And he says the mean circulatory filling pressure. We're gonna get into this later on. It's gonna be easier to explain in the later slides, but it's a pretty easy concept. This basically just repeats whatever I said, that the veins are way more compliant, therefore they're gonna accommodate way more blood. Okay, so here, the venous return. Now, one thing you need to understand is that the cardiac muscle, or the heart itself, does not determine the amount of cardiac output it releases. So the heart doesn't say, I want 6 liters to be pumped this minute. It just says that it just receives the blood from the venous return and it pumps it. So it just acts as a pump. Okay. So what determines how much blood it pumps is the venous return, which is determined by the organs. So, for example, let me give you an example. If I'm exercising right now, then my oxygen consumption to the skeletal muscles will increase, and therefore I require way more blood. And so now this will activate my sympathetics, and I'll cause more venous return through venoconstriction. I'll cause constriction of the veins or more venous return, which will cause more cardiac output. So therefore, what I'm saying is the venous return determines the cardiac output, the amount of blood that is ejected by the heart, not the actual heart. Okay, and basically this is shown here in the chart here on the right. So when it takes you longer to fill the heart, therefore it will take us longer for the contraction, and therefore higher volume will be ejected, or higher pressure. Basically, that's it. And here he just says that different organs, I believe you've also taken this with Dr. Peter, but different organs have different perfusions, and they change depending on their need, basically, for oxygen and blood. Okay. Is it the venous return or the stroke volume which determines the cardiac output? It's the venous return which it's the venous return which determines the cardiac output. Let me put it in this way. If I have 1 liter of blood going into my heart, that 1 liter is gonna be the venous return. Now, this venous return is determining the amount of cardiac output that is gonna be pumped by the heart. If I get 2 liters of venous return from to the heart, then I'm gonna pump 2 liters of cardiac output. You know what I'm saying? So the venous return, the amount of blood that is going into the heart, determines how much will that heart pump. It's not the stroke volume. Can you please explain the graph again? Okay, I'll go over the graph. So this is the period of filling, right? This is the time where the heart fills. This is the isovolumic contraction, where the heart contracts until the aortic the aortic valve opens so that we can reach that level. If my filling time takes longer, therefore my isovolumic contraction will take longer, and my period of ejection will also take longer because you're ejecting more blood, basically. Okay, so you're ejecting more blood by putting more blood into the heart, basically. Is that clear? So in the pressure volume loop, the orange one, the pressure of, okay. During ejection, that is stage 3. Why isn't it straight line, but instead there is a curve? Because you mean this one? You mean this one, the straight line, but instead there's a curve? This one, the blue one, the diastolic pressure. The normal loop. I don't get your question. This one, there's a loop. Okay, this one. Okay, so basically there's a loop because, so in the beginning you're opening the valve, you're gonna be pumping out blood, but in the beginning the valves will not be open. So you know how valves work? It won't be open directly. You're gonna have a period of time until the valves are completely open, which is this increase, and then it's gonna decrease because the amount of blood is gonna decrease and the amount of pressure is gonna decrease. Yes, that's correct, Halima. That's correct. Yes. So the blood, the organs themselves, through venous return, they determine the amount of cardiac output that is released by their metabolic activity and oxygen demand. Can you again explain the 1 liter example, guys? There's a lot of questions. One second. Can you again explain the 1 liter example of venous return? So if I get 1 venous return, this is hypothetically, okay? If I get 1 venous return, 1 liter of venous return into the heart, this will determine 1 liter of cardiac output pumped up by the heart. Okay, this is hypothetically. I'm just telling you so that you could understand the concept. If I get 2 liters of venous return, therefore my cardiac output will increase into 2 liters. Okay. So preload is basically, if I remember correctly, because this is out of the scope of this lecture, but if I remember correctly, and correct me if I'm wrong, it is the amount of blood that is going into the heart. Afterload is the pressure it takes for the blood to eject out of the heart. Yeah, you're right. Preload is EDV and diastolic volume. Could you please explain the relationship between the total peripheral resistance and cardiac output? Okay. If my resistance, or if my vessel's resistance is high, therefore my cardiac output is going to be low, because if my resistance is high, therefore my vessels are going to be constricted, and therefore you can accommodate less volume in the actual vessel, and therefore the cardiac output will decrease. Did you get what I'm saying? Okay, great. Yeah, but cardiac output goes out. I'm talking about the systemic vascular resistance when you talk about them alone. Okay, so an increase in one and others are constant. So Zain, when we're talking about the systemic vascular resistance with the cardiac output, we're considering that systemic vascular resistance increased, okay, on its own. So this is just showing you that if I increase the systemic vascular resistance on its own without increasing the cardiac output, because the cardiac output will also increase in sympathetic due to the contraction of the heart more, and the more contraction and the higher heart rate. You mean going, one second. There's a lot of questions. Also, less blood is going to the veins, so we have less venous return. I don't get what you say, Walid, what you're saying. Sympathetic for vasoconstriction will increase cardiac output. Yeah, but I'm just saying, if I increased the systemic vascular resistance, let me just go back. If I increase the systemic vascular resistance on its own, so I'm not talking about sympathetic, I'm not talking about anything. I'm just saying, if I just took the vessel and constricted it, therefore I can accommodate less, okay? But if I activated the sympathetics, therefore I will activate both vasoconstriction and I will increase cardiac output by letting the heart contract more. You know what I'm saying? So this is assuming, and everything else is constant. So here he says that with changes in total peripheral resistance, putting in mind that the arterial pressure is unchanged. So putting in mind that there's nothing else that is increasing except the vascular resistance. Okay, we'll leave the questions till the end, please, so we can move on. And I may go over what you're asking about later on. So norepinephrine and epinephrine for sympathetic. Okay, and here he just says that there are two sets of blood volumes. The central blood volume, which is found in the superior vena cava, inferior vena cava, and the right heart, and the pulmonary circulation and left atrium, which is basically the vein, basically superior vena cava, inferior vena cava, the right heart, and up to the left atrium, which is 20% of the total blood volume. And then he said that the central blood volume might decrease or increase when blood shifts to and from the extra thoracic blood volume. The extra thoracic blood volume is every vein that is found on the extremities of the abdominal cavity. So every vein that is basically bringing blood to these areas, to the inferior vena cava, to the superior vena cava, okay, they are part of the extra thoracic blood volume. So a decrease in the central blood volume, okay, will cause the thoracic blood volume to pump more blood into the central blood volume. Am I making sense? So if my central blood volume decreased, I'll have thoracic blood volume pumping blood into the central blood volume. So as he says here, blood shifts easily between the veins of the central blood volume and the extra thoracic blood volume. Okay, so in here he just says that what I just said, that the so he says something about central venous pressure. So you can measure this by a catheter. So this stands so PCW is basically the pressure that lies within the pulmonary veins up to the left atrium, basically, which is in the I think it's pulmonary capillary wedge pressure. Okay, so what they basically do is that they basically take a catheter and put it inside the pulmonary artery, and they push it until the artery starts to divide, where خلاص it will stop, because it's not that small in order to enter to the capillaries. When it stops, it will basically measure the pressure that is found in the left atrium, because there's nothing going through that vessel, because you basically just clogged it. And so it will measure the pressure that is in the left atrium. That is why both of them are the same. Basically, this is what he said last, this is what he explained to us last year. And you don't have to know I don't think you have to know the exact pathway, but this is just the explanation of it. And the compliance changes with breathing. As I said, the inspiration will increase breathing rate, so that you have negative intrapleural pressure and more blood flow into the central blood volume, increasing heart rate. And so central blood volume is altered by changes in the total blood volume. If I infuse more blood into the heart, into the vessels, I will cause more blood volume. And the distribution of blood between central and extrathoracic regions. Again, so if I have less central blood volume, the extrathoracic blood volume will pump blood into it, okay, by the veins. The central blood volume, central blood volume again. So it is basically the blood that is found in the inferior vena cava, superior vena cava, left atrium, along with the pulmonary vein, vessels. Okay. Basically, he says here, whatever we said, an increase in blood volume occurs in infusion of fluid. So when you infuse more, or when you cause more retention of salt, and therefore water follows by the kidneys and so on. If you decrease the blood volume in hemorrhage, for example, basically that's it for this. Now, okay, I have a question. So the response to standing, when you stand up, okay, whatever blood that was found in the veins, for example, is going to be pulled down due to gravity, basically. Okay, so whatever blood is found is going to be pulled down due to the gravity, which will cause, okay, so blood will pull into the legs, which will cause lower venous return, because blood pulls down and there's less blood going to the heart. When there's less blood going to the heart, therefore, again, remember, the venous return determines the cardiac output. Therefore, there's less cardiac output. When there's less cardiac output, there's less blood going through the arteries. Therefore, there's less mean arterial pressure. Okay. When there's less mean arterial pressure, I think you took this with Dr. Peter even, that the baroreceptors are gonna decrease in firing, which will cause an increase in sympathetics through discharge through the heart, so more contraction of the heart, which will cause an increased sympathetic discharge to veins, which will cause venoconstriction, so more venous pressure, more venous return, and more end diastolic volume. And then you've got sympathetic discharge to the arterioles, which are going to constrict the arterioles, because you've got decreased mean arterial pressure. So you want to conserve that mean arterial pressure at a fixed number. Okay, so you constrict those arterioles, which will cause an increase in total peripheral resistance. Okay. Here he says the same things, that sympathetic activity would increase basically whatever we said here, the heart, the veins, and the arterioles, which will cause in terms of veins, they will cause more venous return. And the muscle pump, if you are walking, basically the muscles will contract and they will push more blood into the heart. And for ventilation, again, when you inspire, there's negative pressure within thoracic cavity, which is causing more blood to move into the right atrium. And then blood volume, if you increase blood volume, you will increase the amount of blood going into it. Yes, that is correct. Yes, the increase in the intrapleural pressure caused the veins not necessarily to collapse, because it won't increase to an extent that the veins will collapse, but it will decrease the cardiac output because the atrial pressure will increase. So there's less basically gradient for them to move. Yeah, the thoracic cavity, the intrapleural pressure is the thoracic cavity pressure. They are both the same thing. Okay, I think this was the hardest. This was the hardest slide based on what I remember from last year. So basically here, he explains that on one side we have an artery, on one side we have a vein, and then we've got the heart in the middle. Now let's take this scenario first, okay? Let's consider that the heart is not functioning. that I've got blood in my veins, in my arteries, in the heart, but it's not functioning. The heart is not pumping. Therefore, the pressure, this pressure, okay, is this pressure is exerted. This 7 is the mean circulatory filling pressure, which is basically the pressure that the blood itself, the fluid itself, the blood is exerting on the walls. That's it. So the 7 millimeters mercury is basically the pressure that is exerted on the walls. Okay. Now, this is with no pumping of the heart. Let's say I put 1 liter per minute, okay, of 1 liter per minute of blood into the circulation. Okay. Now these are all hypothetical. This is just to explain the fact that the veins are way more compliant than the arteries. Just يعني the numbers don't. What is MCP? Where is MCP mentioned? So basically, one second. So basically, now we're gonna put 1 liter. So again, this is just hypothetical numbers. This is just showing you that the veins are way more compliant than the arteries. So if I put 1 liter and I activated the heart, because the heart, okay, is less compliant, because the arteries are less compliant, they will slightly dilate, but they won't dilate to a big extent. Therefore, the pressure will increase because you're not dilating them. Therefore, the pressure exerted on the walls will be higher. And the veins, when you take the blood, so it's going from the arteries into the veins. In the veins will accommodate the blood and it will dilate. Okay, it doesn't have to constrict. It can accommodate the blood. It can dilate, and therefore the pressure will decrease into 6. The reason it decreases into 6, now this is a bit confusing, is because he says here that the compliance of artery is 1 and the compliance of vein is 24. Basically, how I understood it is that the pressure of the artery, or the artery itself, has a resistance 24 times more of the vein. Okay, so the artery has 24 times more resistance than the vein. Okay, so and let's assume it is per liter. Therefore, if I assume every liter I increase this by 24, I have to decrease this by 1. So don't focus on the math, just focus on the fact that the veins are way more compliant than the arteries. Okay, I know it's a bit confusing. Sorry. So mean circulatory filling pressure. Okay, so basically it's just telling you that the veins are way more compliant than the arteries. And then here he just says that if I put 4 liters, the pressure becomes 103 because you just considered 4 times the 24, and then we add them onto the actual mean circulatory filling pressure, which is the pressure exerted on the vessels without any help by the heart, and which is in here is 103. But here, because the veins are whenever we add volume, they keep dilating. Therefore, the pressure will decrease. Okay, these numbers are only hypothetical for you to understand how they are going. You cannot say cardiac output is inversely proportional to the venous pressure. It really depends on the case. So is everything okay with this? So basically, he says here that the heart is, when we stop the heart, basically the mean circulatory filling pressure is 7 millimeters mercury, which is the amount of which is the blood, which is the pressure which is exerted on the walls. Okay. Okay, so great. Does an increase in cardiac output lead to a decrease in venous pressure? We will get into this later on, but we'll get into this later on. So Firas, wait, we're gonna get into this later on. I will be able to explain it better with the graph that we will show later on, which is basically related to the venous return. So given that everyone understood this, great. Here he goes into the fact that again the veins are compliant more than the arteries. How? Let's say I'm at 3 here, okay? I'm at 3 liters, okay? And I add 1 liter into the veins. As I added 1 liter, look at how the pressure changed, okay? So it's changed from about 10 or about 7 into about 40, okay? At 4, okay? At 4. If I start here at the same spot in the arteries and I add the same amount of volume again, okay, it will take me or I will add less amount of volume, sorry. So if I add a little amount of volume into the arteries, this will cause a much more increase in pressure. So the pressure of the arteries increased dramatically with a little bit increase in volume, while the veins can accommodate a lot of volume with a slight increase in pressure because of the fact that they are compliant. They can basically dilate, okay? And basically what he says here is that when the veins contract, okay, or they increase their tone, basically they become less compliant, because when I contract or when I increase the tone, I will not dilate. I will not have more room, okay? And so I will decrease the amount of volume I can, I will decrease the, so I will increase the pressure, which is in, okay? Is everything okay? I feel like I'm confusing a lot of you. Me? See, I know, wallahi, I know this is confusing. I told Idris to, I told Idris to send you this. I'm sorry, I'm really sorry if you're not understanding something I'm explaining. I'm trying really. I have my notes from last year, so hopefully after I finish this session, I'm gonna send it to you, and hopefully it's gonna help you. Hopefully it's gonna help you. Okay, so let's continue. So does everyone get what I'm saying here? If I add, okay, if I add 1 liter in the arteries, it will cause, if I add 1 liter in the arteries, it will cause, for example, a 3 millimeters of mercury increase in pressure, okay? If I add 1 liter of blood into the veins, it will cause a 0.5 increase in pressure. Basically, due to the fact that these arteries cannot dilate, are not as compliant as the veins. That's it. Okay? Clear? So I can repeat this. I don't mind, but please tell me if you don't understand it. Okay. Okay. So let's say I have this vessel. Let's say I have this this vessel, okay, and I added into it 1 liter, okay, and this vessel I cannot distend this vessel, okay, so I put it into a vessel, but it cannot distend, it cannot accommodate, okay. You know how water, when you distend a vessel, or when you distend a water bottle or something, okay, it will go into the least area or so, okay. So if I put 1 liter, the arteries will accommodate that 1 liter, but they will not dilate. They will constrict, okay? They will just accommodate that liter, okay? And make sure that they don't dilate, so that the pressure doesn't decrease. If I put that same liter in the veins will dilate. because the veins are basically the pool. They will basically dilate to accommodate. That is why again, this pressure decreases as we put more liters into it. Because as we put more liters into it, considering that no sympathetic is included, nothing is included, just this blood is put there, okay? The veins will dilate so that it can accommodate the blood, because it is compliant. It allows it to, okay? If veins are more compliant, how come the pressure is the same for arteries and veins when the flow is zero? No, when the flow is zero, here I'm telling you that the pressure is the same when there's nothing happening in the body. So if I take the body and nothing is happening, so the veins aren't compliant, it's basically two tubes connected to my phone, for example. Here there are two tubes that are connected to it, okay, from here, okay, and my phone is the heart, and the blood is not moving. Nothing is happening to the veins, nothing is moving to the arteries. They're both this pressure is basically the pressure exerted on the vessel, okay? The vessel, nothing is happening to the vessel itself. There's no effect is happening to the vessel. Okay, so moving on, I'll try to go over all of your questions before I finish, inshallah. Okay, for this, so effects of cardiac output on mean aortic right atrial pressure. Trust me, this lecture was so confusing last year too. Just try to solve as many questions as possible. I know it's confusing, trust me, I know. And it took me a lot of time to actually understand it. So when I decrease the cardiac output, this results in a rise in right atrial pressure and a fall in aortic pressure. How can I explain this? So if I pump more blood, okay, into the if I pump more blood into the aorta, okay, basically what's going to happen is that you're going to have more blood going out of the aorta, and you're going to have less blood in the veins. Therefore, the venous return is less, and therefore the higher the atrial pressure. I feel like I confused you all. That's what he said last time. I'm really sorry, but that's what I understood from him. So basically, when you pump more pressure into the aorta, okay, you're gonna have a higher right atrial pressure, okay, until the blood actually goes into the veins, and the right atrium will and the veins start moving the blood back to the right atrium again. Okay. Trust me, I know. Wallahi, I know it's confusing. Okay. So, let's say I have 1 liter of blood. I pumped it out. Okay. Now I can accommodate. I still have 4 liters of blood within my body. Okay. That can go back to the heart and pump it in the next time. Okay. So if I pump 3 liters, let's say we increased in pressure, we increased in the cardiac output. We increase in the cardiac output. What he basically says that what he basically says that if I increase the cardiac output, if I increase it, for example, to 3 liters, therefore I have 2 liters left in the body. And so if I have 2 liters left in the body, I will have less blood pumped the next time. Okay, that's why the right atrial pressure will increase. So until that blood that I just pumped goes back to the venous circulation, I will have a higher right atrial pressure, basically. Okay. I'm hoping everything's fine. I know it's confusing. I swear I know it's confusing, but that's how I understood it, to be honest. And trust me, yani, I just memorize it as it is. I hope I'm making sense. I hope I'm not confusing you guys or boring you guys. Okay, so here he basically says that he says the same thing. So see, he says the same thing. So as I increase the cardiac output, the venous pressure will increase because there'll be less, the right atrial pressure or the venous pressure will increase. There'll be less, basically, blood in the, there'll be less blood in the veins, okay? And therefore, you'll have to constrict the veins and move the blood upwards. That's why it constricts, okay? And yeah, venous pressure and right atrial pressure are usually used concurrently. It's fine. They usually use it concurrently for some reason. The doctor last year used it concurrently. He said they are both the same thing. So basically what I'm saying, that as I increase the cardiac output, the venous pressure will increase due to the fact that you have less blood in the veins. And therefore, if there's less blood in the veins will constrict so that we can have more venous return, so that I can have a next cardiac output. Okay, so if I pumped a lot, if I pumped 5 liters, for example, of blood, or 6 liters, okay, so, or 6 liters, so I'll have less blood in the venous side, okay? So I'll have next time, so for the next pump to occur, I have to increase the venous pressure so that the blood can move into the right atrium. Do you know what I'm saying? Okay. It should decrease. It should decrease. Yeah, shouldn't it should yeah, it should decrease if yeah, it should decrease, but you are forgetting one thing, that if يعني hypothetically, if there is no control over the sympathetic, okay, then it should decrease. But because there is control over the sympathetic, it will cause the veins to constrict, because I pumped a lot of blood through the arteries, so I need more blood to go through the veins. Do you get what I'm saying? So I have 3 liters going through the arteries, and I have only 2 liters through the veins. Okay, and for the next pump to happen, I need to constrict the veins and increase the venous pressure so that I can have a higher venous return. So this is the effect of the sympathetic on the venous pressure. Okay, okay. Great. So everyone got it. Everyone got it. Okay, great. Okay. Here he's just explaining the venous return curve, which basically happens here, where if I increase the venous pressure, okay, so basically last year he had arrows on this. So basically, if I increase the venous pressure, I will increase the venous return, and therefore by increasing the venous return, I'll have a higher cardiac output, and then by having higher cardiac output, you'll have a less venous return, and this is a loop, okay? And so usually it happens around this, but usually it occurs at this place, okay? So can we just think of it? Yeah, basically, تقريبا, yeah. That's how I understood it. Okay, Maha? Okay, great. Good luck, guys, on your midterm. I'm really sorry for confusing you. I'm really, really sorry for confusing you today. So basically, usually the normal cardiac function is around this area, where I have the right atrial pressure at +2, okay, and I have the venous return coming and the cardiac output coming in the same amounts, okay. And when there's an increase, for example, in venous return, as I said before, there's an increase in cardiac output, okay. If there's if there's a decrease in venous return, there is a decrease in cardiac output, okay. I hope I'm saving you. I hope. Okay, for here, let's say, so for hypervolemia, let's say I infuse a patient with more blood. Let's say I have 5 liters in the blood. Normally, I infuse him with one more liter. Okay, if I infuse him with 1 more liter, therefore more volume will occupy the vessels, and therefore there is more venous pressure. If there is more venous pressure, okay, this will cause more cardiac output. Okay, so venous return is going to be higher, basically. Okay. If I decrease the venous tone or hypovolemia, okay, so if I decrease venous tone, that means I cause vasodilation, basically, the vasodilation of the veins. So I'll have more pooling of blood downwards, okay, and therefore I'll have less cardiac output, okay. Or for example, in hypovolemia, for example, in the case of hemorrhage, okay, in the case of hemorrhage, okay, you're gonna lose a lot of blood. And therefore, the cardiac output is going to decrease because there's less blood reaching the veins, the heart. The venous tone is basically is basically how can I say this? Is how contracted is the vessel. Okay, so basically, a normal tone would maintain the pressure. Okay, and the tone would increase and decrease depending on the sympathetic, depending on the volume, and so on. Are venous pressure and venous return directly proportional? I think it is. I'm not sure about this. You'll have to ask the doctor. I won't lie. I'm not sure about this, but I'm pretty sure it is. Yes, if I have more compliance, okay, I'll have less venous pressure, okay? Yes, you're correct. Okay, this for hemorrhage. Flow is basically venous return, which is proportional to pressure. Oh, okay. Here, the hemorrhage, I lost 1 liter. My body has 5 liters, I lost 1 liter. Okay, if I lost 1 liter, therefore I have 4 liters in my body. If I have 4 liters in my body, then therefore my blood volume decreased. If the blood volume decreased, therefore the venous pressure will decrease. Okay, and therefore the venous return will decrease because the venous return decreased because there's less blood basically in the veins. Okay, and therefore if the venous return decrease, there's less atrial pressure because there's less blood going into it, and there's less cardiac output, so less diastolic volume, and there's less stroke volume, and so there's less mean arterial pressure. Remember that equation: mean arterial pressure equals cardiac output times systemic vascular resistance. Okay. Now, as I have that, I will have decreased firing of the baroreceptor, just like the stimulus that happens in response to standing up. Again, you're going to have a decrease in firing of baroreceptors. You're going to have an increase in the sympathetic discharge, which is going to cause more contractility of the heart and higher heart rate, so that I could pump more blood. Then you're going to have sympathetic discharge to veins, okay, so that I could venoconstrict to cause more venous return. And I'll have sympathetic discharge to arterioles because I pumped because here we said that there's less cardiac output. Therefore, my mean arterial pressure will also be down. Okay, so my arterioles constrict because I wanna bring back the pressure back to normal. Okay, and this is basically it. Okay, so for this, the effective arteriolar, how can I move this? The effective arteriolar vasotone on venous return. Okay, so a change in arteriolar tone has a different effect on the vascular function curves than a change in venous tone, because as you can see, a change in arteriolar dilation. This is basically what we mentioned before, that if I have higher systemic vascular resistance, okay, I will have less cardiac output, which is here. Okay, if I have less systemic vascular resistance, I will have arteriolar dilation. Therefore, I'll have more cardiac output. That's basically it. Okay. I hope this is simple. It's pretty straightforward. He just confuses us with the venous pressure. You always could. Is this okay? Any questions till now? Okay, no. If you have any questions, let me know, please. Okay, this is the last slide. So there are two things that we need to consider: inotropic effect and positive inotropic effect and negative inotropic effect. Okay, so I don't know if you've taken what is an inotropic effect, but an inotropic effect is basically so a positive inotropic effect is basically more contractility of the heart. A negative inotropic effect is less contractility of the heart. So changes in inotropic state, which is contractility of the heart, alters the cardiac but not the vascular function curve. Okay, so a positive influence or positive inotropic effect, like here, would increase the cardiac output. So if I'm what would be a positive inotropic effect? The sympathetics. Okay, the sympathetics would cause a higher positive inotropic effect. I think he mentioned digoxin to you or digitalis to you, where it will cause higher contraction of the heart. That's a positive inotropic effect. Okay, and then you've got a negative inotropic effect. Negative inotropic effect are things like the parasympathetic, which would decrease the cardiac output. Okay, and therefore you're going to have, which will decrease the contractility of the heart. Therefore, you're going to have less cardiac output, less blood contracted by the heart, basically. No, less inotropic doesn't mean preload. So it's not related to the preload. Okay, so yes, epinephrine is a positive inotropic effect. Okay. Does negative inotropic means higher preload? It's not associated with preload. It's associated with basically the heart. So inotropic is only associated with the heart. So inotropic is basically associated with the contractility of the heart. Okay, so a positive one, which causes more contractility of the heart. It's not associated with the vessels, not associated with anything else except the heart. Okay, so when I talk about inotropic effects, I talk about the heart. Okay. I think I'm done with my slides. Here are some questions. The first question is: in which of the following conditions would you normally expect to find a decreased cardiac output? I'm going to open the chat. Please tell me your answers in the chat. Okay, great. Everyone's saying E, but there's someone who said beriberi. I want to know why. I want to know why you said beriberi. Acute basically how can I explain this? So acute is acute in general means not that long lasting. So it just happened. Okay. Chronic means over a long period of time. Okay. Why is it not D? Okay. So the reason it's not D is because let me get you back into one slide so that I can show you. Okay. There's this slide. So if I increase the hematocrit, the blood viscosity is going to increase, okay? And therefore the total peripheral resistance will increase. Basically what I'm saying is that in anemia, there will be a decrease in the RBCs. And if there is a decrease in RBCs, therefore there will be less blood viscosity, okay? And I believe you took this with Dr. Peter, and therefore there will be less total peripheral resistance. Thanks, Rafi. I hope I did, wallah. I think I confused them. Okay, I hope this question is clear. Wallah, I know this lecture is confusing. Trust me, I know this lecture is confusing. It took me a lot of time to understand it. Inshallah, I did. Inshallah, you all get A's in the exam. Inshallah, you all get A's in the exam. So for this question. Okay, great. I'm very happy. I'm very happy. I'm very happy that everyone's getting what I'm talking about. I'm very happy. Like this is the last question. Okay, great. Most of them are saying E. I saw an answer and it said okay, someone said C and someone said I saw someone saying D, I think. Yeah, someone said D. Okay, so why is it E and not C and D? One, if I have a decreased sympathetic tone, therefore my compliance will increase. Okay, and if I have an increased venous compliance, therefore my veins are gonna accommodate more blood, and I'm gonna get less venous return. Yes, exactly. So C would dilate the vessels, would dilate them. Okay, so I would pump less blood, I'd get less venous return. Okay. Sympathetic tone is not the same as the venous tone. Based on what I remember, is that sympathetic tone is basically when it causes constriction. Okay, venous tone is the normal tone of the vein, basically. Can I please explain question 1? Okay. By the way, if any of you are I don't know, are lazy to go over the recording again to see the explanation of the questions, I already put in notes section the explanation of each question and why every answer is basically wrong. So basically, what do you want me to explain? So in acute MI, there's a decreased cardiac output because there's less recruitment of the muscle fibers, basically. Okay, you have less recruitment of the muscle fibers, and the heart is failing as a pump. Okay, so there's less cardiac output, basically. I hope this was helpful. Inshallah, this was helpful. Allah yufikkum in the exam. Inshallah, you'll all get A's, inshallah, in the exam. Okay, for a hyperthyroidism, it will increase. Okay, so again, let me show you again. Okay. Here, where is this slide? This one. Okay, we said hyperthyroidism will increase cardiac output. Remember, we said hyperthyroidism will increase cardiac output. We said because you have more oxygen demand from the organs, and because there's more oxygen demand from the organs, there's gonna be higher perfusion. There's more contractility of the heart. In beriberi, we said there's higher cardiac output. Don't don't focus on beriberi. You didn't take the specifics of the disease, so don't worry about it. Again, AV shunts. If the remember we said AV shunts are the shunts that are going from the artery to the vein directly. Okay, so if they are going from the artery to the vein, therefore there's more fluid going to the venous system. Okay, and therefore there's more venous return basically. Also, I'm very sorry, guys. I couldn't do it in uni. I had a bit an issue. Yeah, we're gonna post it on the PAL YouTube, inshallah. And yeah, yes, we will. Again, I'm hoping so. So any vasoconstrictor has a positive inotropic effect. Inotropic effect is not determined by the vessels. The inotropic effect is determined by the effect on the heart. Inotropic effect is only on the heart. Don't get it mixed up by the vessels. The vessels have nothing to do with this. Okay. Okay. So this only alters the cardiac function. Okay. Polycythemia will, yes, based on what I remember, they will decrease cardiac output. But please double check since I've taken this like a year ago. You are welcome, guys. Polycythemia is basically when you have more than normal blood vessels. Inshallah, you all do well. Inshallah, you all get A's. Don't worry, don't panic. Just solve as many questions as you can. Focus on Guyton, please focus on Guyton. And for anatomy lectures, Michigan, please. About the catheter, okay. Although this was for your knowledge, but okay. Inshallah, you will all get A's. Inshallah. Okay. What is your question? Anytime. Good luck, guys. Good luck. Safia, I'm sorry if I'm pronouncing it wrong, but what is your question? So the second point, changes in central venous pressure is an indicator of central blood volume because the compliance of the intrathoracic vessels are constant. The inspiration increases the negative intrapleural pressure. To be honest, I don't know why you need to ask him about this. I cannot answer this. I really don't have an answer for this. But based on what I know, what I know from last year, is that basically the central venous pressure itself does not change, but the extrathoracic does change. Okay, so extrathoracic will move blood into the central venous pressure to keep the central venous pressure or the central venous volume the same. Okay, but I don't know why he says that it changes with negative intramural pressure. Maybe because the vessels, you've got negative intrathoracic pressure, and so the vessels are gonna dilate, and therefore you're gonna increase the therefore you're gonna decrease, sorry, the mean the arterial pressure, the right atrial pressure, and therefore more venous return basically. That's how I'm thinking of it right now. Based on what I know last year is that it is constant. Based on what he said last year, it is constant. What changes is the extrathoracic. From last year, he said that extrathoracic is what changes. The intrathoracic usually doesn't change. Again, I'm really sorry if I'm confusing you, but that's what he said. I believe, Idris, that's it. I think everyone's gone. You can send them the PowerPoint, please. You can, wait. Okay, stopping